Are on our sixth anniversary. This is the sixth anniversary of the webinar. So we have come to talk about all of the wonderful things that the webinar has brought to fruition. We have got a wonderful line of panelists. We've got a wonderful group of people here today to talk a little bit more about physical therapy. We're going to talk about what you should know about penicillin allergies. But first, I want to go down memory lane a little bit with Jim Malinowski and Dr. I thought I saw Dr. Ash and I saw Yvonne Lewis. So we're going to talk a little bit about why we're celebrating 6 years and what those 6 years have looked like in terms of bringing trusted information to the community. So if we could spend a little time talking to Jim and Yvonne Lewis, it would be great to sort of remember. Tell me a little bit about how the webinar got started. I want to talk to each of you about how you got involved in the webinar. And I know Yvonne and Jim have sort of those stories about why we needed to come together and why we needed to bring this information to the community. So I'm going to hand it to you a little bit.
Well, I guess good afternoon, everyone. It's great to be here. Uh, this opportunity to talk about what's happened over the last 6 years when we got started with this webinar. The Flint Center for Health Equity Solutions was planning a symposium or annual symposium where the Healthy Flint Research Coordinating Center actually was planning the symposium as a part of this. And the Healthy Flint Research Coordinating Center comprised of partners from the University of Michigan, Ann Arbor, Flint, Michigan State University, and our community representatives that at that time was CBOP, community members, and the National Center for African American Health Consciousness, talking about continuing our work with the symposium, but we got that notification that we had to shut things down because of COVID. And so COVID created a really interesting little bubble for us. So what do we do? How do we continue to get information? A lot of things we did not know at that time. So one of the things that we thought about during those conversations with the Healthy Flint Research Coordinating Center Executive Committee was how do we bring information about this virus, which nobody understood at that time, nothing about. It just was a tremendously horrible situation. And that coupled on top of the water crisis, which was why the Healthy Flint Research Coordinator Center was organized to address the issues of research as it related to the water crisis. So all of that created an opportunity for us to develop the webinar to share with our community from trusted voices where resources were, how we could really understand what was going on with the virus. Let's talk to people in our own community because we heard commercials, we heard news reports, but what do the people in our community say? And where do we go to get not only information, but access resources and access those resources in an equitable way? So the webinar was an opportunity for us to bring partners together like the Genesee Health Plan, the My Children's Health Center, our hospital partners, Greater Flint Health Coalition, the Health Department, bring all those voices together and tell us as a community what it is we needed to do, where we could find resources that would address the issue and help us move through this crisis, which we really had no clue about.
Yeah. It's as a physician, there are not many positive memories from COVID, but the idea that community came together and people in community came together to make sure that the community was educated on what was happening, how they get resources, and what to do really is sort of at the crux of what it means to be a preventative physician for me, a family doc. And so I want to talk to Jim a little bit about the role of GHP and sort of providing resources to the community. And then I'd like to talk to Dr. Ash about her experience with that time as well. So,
Well, when I would come on the webinar, I would talk because we're very blessed in our community that people have healthcare coverage for the most part. We help people with the uninsured and help them get and keep their like Medicaid and other coverages. But I tell you, people, didn't know how to access services or what kind of services were available. And so, we spent a lot of time talking about, how to, keep your coverage, how to get it if you didn't have anything. A lot of people were losing their jobs, what we call gig workers, people who worked at bars or salons. They were shut down. And so those folks all of a sudden needed to be in that system and how to apply and all that. So we would spend a lot of time on that. But it was also, as Yvonne talked about, a source of information. So for me and our staff, we'd have all of our staff listen to the webinar because it was certainly better information and more current information from the experts at Heatherland and Yvonne. It was almost like a full-time job, I feel, for
Mhm.
Heatherland and Yvonne doing this webinar and all of the planning. And the last thing I wanted to say is that, Heather and I we did a number of conference appearances talking about the webinar and, a few years after and while we were still doing these. And people in the country were just amazed how
Yeah.
we did this here in Flint and how, we use the different universities and different health systems. And you don't see that a lot in other communities. There's usually a lot of separation there, and that was the amazing thing that people couldn't believe that we did this, and really they were like, "Oh, I wish we would have done this ourselves."
Yeah, that's such a really great point. Like to be able to bring all of those institutions together to work to solve a problem is sort of at the core, the mission of what we do in Flint, right? We are leveraging our community partners and thinking about how we make sure we get resources to people when they need them and how they need them. As I think about Dr. Ash, you didn't get an opportunity to join the webinar until more recently. And as you've kind of had the experience of being able to hear sort of how quickly and how valuable the webinar has been in being able to provide resources to the community, can you talk about where you see the webinar potentially being able to go, particularly as you've brought that pediatric lens that we haven't been able to kind of talk about as much? And what do you think we have the opportunity to do with the webinar in the future?
All wonderful questions. I do want to comment on what Jim said, though. This is
Yeah.
what I tell students when I recruit them to my program into Flint is that nobody does it like Flint. Really, truly. We mobilize our community. Everyone gets together, physicians side by side, business owners, and it's an incredible thing to be part of, and I'm honored. Yeah, I started helping out with the webinar and being part of it, like I think a couple years ago. And another thing that I'm very honored to be a part of because it's such an important part of what we do as physicians and as community is, how do I take what I know and what I study and I'm interested in and share it with the world because it's not something that needs to stay just with me. It's not like hidden knowledge. And that's a really important part of uh, I guess helping the health of people in general, right? Not just in those clinic and those hospital settings, but how do we make sure our community is healthy and aware and alert, and the first to know about things. So I think going forward, continuing to be the people who are very timely in our approach, right? So you hear about measles on the news. Hopefully, you heard about measles here first, right? And hopefully, you feel very confident in your awareness, knowledge. I think another part of this, and we've been getting a lot more people reaching out to us about what their priorities are, what their interests are. And I really do hope that continues. One thing that Heatherlyn and Dr. EJ and I have really talked about a lot is what are the priorities of other people, right? I think we can, think of topics regularly, but what do other people want to hear? Because that's really important as well. What are you, Googling and going to Chat GPT about, and how can we help with that as well? Um,
Yeah. I
and then
think you
for
just gave us another webinar topic, like how to use GPT in medicine. How
yes.
can we leverage that resource? But yeah, sorry.
No, that's okay. And then the pediatric lens, I'm always passionate about those little kids and getting the word out. And especially in a time like this where there's so much misinformation and disinformation around things like vaccines and, even as like nutrition, formula, I think it's a really important thing to share, but also people don't talk about kids as much as they should. So I'm hoping to continue to be part of this. And then the other part of it is, and this is a little selfish of me too, is having medical students on, training that next generation to know how to provide important health education, know how to interface with our community, know how to understand what priorities might be, I think is really important. I say it all the time. I think our healthcare system and health system is a little broken in the communication aspect. And so if we can do our part in having students understand the importance of community and community education and dialogue, I think that's my dream. It's my pipe dream.
So all four of us represent some corner of what came to start the webinar. We've got GHP, we've got community, we've got, physicians in community, we've got our hospital system representation. And one of the things I heard you say, Dr. Esch, is this idea of we want to make sure we're hearing from the community to understand what topics we might consider, particularly as we move into the future. That is the purpose of this webinar, just to be like very sort of abundantly clear. Our goal is to make sure that the questions that community has, that the things you're worried about, that the things you're unsure of, we can bring some trusted expertise that we've vetted, we've understood. They're going to bring the expertise that you need to know, and they're going to break it down in a way that you can know what your next step is. You can know exactly where you need to go, exactly what your next resource is. And so we want to hear from you. We want to make sure we're understanding what your needs are. I'm super, super appreciative to be in community with all of you. So thank you so much for all that
And
you have done.
Doctor, if I could,
Go ahead.
EJ, if I could just
Yes.
say one of the things that's really critical, and you mentioned that, is that the community responses to the community's needs. And so again, we want to appreciate the community, because without the community coming on and listening to the webinars and then taking advantage of the opportunities that were presented, this wouldn't have been able to continue. So it's evolved from community coronavirus to just overall community issues. But certainly we want to appreciate the community and all those partners who have continued to stay the course and help get this information out to our community members. So thank you.
And we should leave it there. Thanks, Yvonne. All right. Thank you so much for celebrating with us the 6th anniversary. Today, we're going to talk about a concept that I experience a lot in the office, this idea of penicillin allergies, and we're seeing it more in the headlines. And so we've brought the wonderful Dr. Raffi. I can't say enough. Dr. Raffi has won teaching awards from our medical students. He will break down very difficult concepts into things that are understood. When my own son had a sinus infection, he sat with me and we figured it out together, and I can't say enough wonderful things. So he's going to help us think about penicillin allergies and what we should be thinking about.
Thank you, Dr. Edward Johnson, for this introduction. I'm happy to be again on this platform one more time. I'm sorry for my camera not working today or not behaving today, but I'm happy to be part of this platform or webinar. Great. What I heard is all great things about you guys. Definitely unique idea and unique thing that you guys do here for our community. I don't know what you guys have particular question, but I can talk a little bit overview about this topic, and then you guys can ask me questions. So again, this is, first of all, also I want to thank Dr. Esch for reaching out to me about this topic, because I'm really invested in it. We have a quality improvement project that we do with our residents for the last year or two here in our hospital at Hurley, trying to address this issue. So basically, penicillin allergy is very commonly reported. Almost like 10% of our population will say that they have allergy to penicillins, which is a group of antibiotics that include penicillin, amoxicillin, ampicillin, this kind of group of antibiotics. So it's reported commonly, but true allergy is really rare, less than 1%. And this our knowledge about this topic has changed significantly. Like 20 years ago, when I kind of started my residency, it was really like a scary thing, like, oh, penicillin allergy, you take it for granted and you don't give penicillin to these patients. Also, we go further and worry about giving other antibiotics that we maybe call them cephalosporin, or they are like cousin of penicillins. We also worry about them because of initially what we knew that maybe there's some cross reaction that happened. But definitely the information and what we learned over the last 20 years about this topic has significantly changed our understanding of it. And that's why I say simply, it's commonly reported, but it is rarely true. And there have been recent push from the CDC and other hospital medicine societies at trying to address this issue, starting with a proper history taking, proper documentation of what we mean by, or what the family means when when they say that there is a penicillin allergy, to really address it and maybe even do testing to verify this reported allergy and then remove it if it's not there. And it's a process that really we have been doing here at Hurry for the last 2 years. We have been teaching residents also about how to do it. And the implications of not having good documentation or not, through allergy is really significant for the patients and their families. I'm talking about kids, but even for adults, it's the same percentage, commonly reported, rarely true. The implications is that you are not allowing the use of a common antibiotic group that is really safe, well tested, very effective to many infections. So by labeling someone has penicillin allergy, you prevent them from using this, and let us physicians rely on the second and third line antibiotics that have more side effects, more broad spectrum, like it kind of kill blindly everything, has more interactions, more costly, not as effective. You catch C. diff infection, a lot of side effect from using what somebody might call them stronger broad spectrum antibiotic. That's not good for the patient, not good for the community. You promote more resistant bacteria. We better use a targeted specific antibiotic. So that's why it's really important, everybody, start with the families, by reporting what they know about the allergy, not necessarily just label your child as having allergy. Ask your physician to see if this is really more of a side effect of the medicine, nausea, vomiting, that commonly get reported as allergy, but this is really side effect, does not require to have a label in the chart that you cannot get amoxicillin or penicillin in the future. Many families, from my experience, they will label their child as allergic to penicillin. And when you ask a little bit more, they tell you, oh, I have allergy to penicillin. And we know it's not a genetic thing. We know it's not an inherited thing. And actually, these families need to be assured, explained, educated, and their kids don't need to be labeled as having allergy to penicillin. These are some examples of common kind of misconceptions about penicillin allergy. Kids get rashes all the time, and they get amoxicillin a lot. So always we make this connection between the rash and the amoxicillin, but really studies show that this is really not true. And many times this rash that you see is really not related to the amoxicillin. It's really more related to the underlying virus. Actually, there are more studies show that maybe that combination of amoxicillin and having a virus might promote the onset of some rashes, non-specific rashes, that doesn't indicate true allergies. And that you don't need necessarily to label a child as having penicillin allergy based on that kind of story. So it really goes back to really having a good history. And that may be the role of physicians. Sometimes in our busy clinic schedule, we don't want to ask more questions about the nature of that reaction, and we just label somebody as having amoxicillin allergy. And there are scenarios where we're not sure, even as physicians, like the reaction was severe, required somebody to go to the emergency room because they had trouble breathing, they had blistering of their skin. This kind of reaction definitely require more testing, like an allergy referral and skin testing. I won't say that they don't have allergy. So it really go back to good history and good relationship between the physician and the family or the patient to really document appropriately or accurately if they have true allergy or not. I can go on and on, but I will stop here. And
that's perfect time to stop because we have a wonderful question in the chat. And I know the answer, but I want to hear your answer to this. So one of our panelists says, my lips started swelling after taking penicillin as an adult. Would you say this is an allergy to penicillin?
Okay, good question. So I will use this as a prime example about like really that information alone by itself won't help me alone to decide if this is what we call it like a low risk versus high risk scenario. So we need to know like how severe was the reaction when it comes, how soon it happened after the amoxicillin. Did it happen same half hour, 1 hour, or it happened 2 days later? What other symptoms? Was there trouble breathing? Was there a rash? Did you go, need to go to the emergency room because you have, your airway closing and trouble breathing? Did you take other antibiotic? Many times families might have received another antibiotic that has amoxicillin. A year later, they did not know that it has amoxicillin, but it was amoxicillin and did not react to it. So having some tingling, numbness in the lips might concern me, but I really want to know more about to be able to determine if this is low risk. And here, what I mean by low risk is really some nausea, vomiting, or some non-specific rash or hives. If it does not belong to any of these group, I will advise my patient to go and get skin testing, to an allergist. It's a routine thing. They can test you for penicillin. They can do skin testing, small dose of a penicillin under the skin to make sure you don't react to it. And if it does not, they'll challenge you with an amoxicillin in the office under controlled environment, to treat you and delabel that allergy. So that is also important to know because you really don't want to kind of label yourself allergic to penicillin for life. One other thing I think important information to mention, that allergy to penicillin wanes by time. So even if you have some allergy, and it has been, especially for adults, more than 10 years passed by, you probably don't have any more of these, what we call them immunoglobulin E, or these antibodies that cause a reaction. You probably don't have enough of this antibody to cause reaction. So maybe it's a good opportunity if this was an old history to maybe go to an allergist and get skin testing and confirm that you really don't have reaction, and then you can safely get penicillins.
So I want to make sure I have this right. So if someone comes in, takes amoxicillin, and they develop swelling in their lips, definitely a thing they need to stop. Definitely a thing they need to be seen for immediately to make sure this isn't something that's progressing. It's not something that's going to lead to shortness of breath or an airway issue. So definitely get in with your doctor right away. One of the questions that was asked was about should they take Benadryl right away. I'm gonna throw that question to you in a second, but I heard stop taking the medication, be seen by your doctor, immediately. That we potentially, if there's numbness and tingling in the lips, it could be an allergy, but it could be something else that's going on. And one of the ways that we have to test that is to do the penicillin skin testing. So you might ask your doctor, once you've been seen and cleared, if you should see an allergist to make sure that you're not allergic, or to understand whether you're allergic or not. And then you were saying also that allergy can go away over time. So if you were diagnosed with the penicillin allergy as a kid, you may not have that same allergy as an adult. Did I get all that right?
Yes, very nice. Well put summary. Definitely. I think those are maybe what you could call them take-home message. Really, I want to emphasize that's not your decision or the patient decision to label themselves as having low risk versus high risk. What we want to spread that's really rarely is a true allergy, but definitely follow up with your physician, who going to ask you a lot of questions to know the exact nature of it, and then based on that, the options will be either do like an oral challenge in the office. If it's very low risk, they'll do it in the office or in the hospital setting, or skin testing, an allergist and skin testing, or maybe they'll tell you this is so serious, don't try it again.
Got it. What's the role of Benadryl when people have an allergic reaction? Is that something people should have on hand to make sure they're not at risk?
Yeah, it's a good idea, definitely. Somebody get hives, get numbness, swelling of their lips, and while they are seeking some care, getting a dose of Benadryl helps. But if it's a serious reaction, they need to be seen right away. If they have trouble breathing, difficulty swallowing, a feeling that their throat is closing, you need epinephrine shots. You need different treatments to stop that reaction. Benadryl is supplemental medicine that can help with mild reaction, little hives, for example, and we do it in case of severe anaphylaxis. But it's not enough. But given it for many of these mild reaction, while you're calling your doctor is a good idea.
So anaphylaxis is when your throat closes up and you can't breathe and you have a release of your reaction, right?
Correct.
All right. The other question I have is we have talked a lot about what happens when we take penicillin. Will you talk to us a little bit about what we would prescribe penicillin for? So why might someone be taking penicillin?
Good question. It's really commonly prescribed antibiotic. At least I can talk about my experience with children. I mean, it's a number one first-line antibiotic for streptococcal sore throat, or what we call it streptococcal pharyngitis, so infection of your throat. It's a first-line antibiotic for ear infections, first-line antibiotic for sinus infection, first-line antibiotic for pneumonia. So as you could see, those are the most common infection in children. Ear infection, sinus infection, pneumonia, these upper respiratory infections. So it's really commonly prescribed. So when we end up labeling a child having amoxicillin allergy, which kind of make us afraid of using it and go to a second and third line antibiotic that is really not as good as amoxicillin or has far more side effects than your amoxicillin. So it's commonly used antibiotic.
That makes sense to me. So this is one of our first line medications for for many different illnesses that are caused by maybe strep, as you alluded to. So when you hear strep pharyngitis, that's strep throat that we kind of hear of in regular society, or ear infections and things like that. This is one of our main treatments for all of those things. And if we have so many people who have allergies, then it means that we're going to have to use antibiotics that are not first line one, but two, that might be stronger and sort of have more of an impact on our immune system that we need to. Which brings me to my second question. You mentioned C. diff earlier, and I wonder if you would explain what C. diff is to people so they know.
Good question.
Sort of
yeah, definitely. Like. So it's a bacteria that we could have it in our colon or in our guts. So, we all have this kind of normal flora, normal bacteria in our intestine and our colon, which is part of the normal healthy flora that we all have in our bodies that can help your body make vitamin K, can help keep a balance. Very important. When you give the strong broad spectrum antibiotic for no good reason, you kill many of these good flora or good bacteria in your intestine, which allow this opportunistic bacteria that we call it C. diff to take over and cause diarrhea, bloody stool, stomach pain, colon inflammation. And, you can get really sick from it. So it's a bacteria that we really worry about in case of giving antibiotic that can kill the good flora that is normal and healthy part of your body and healthy part of your immune system, actually, even.
That's so helpful to understand. If I were to wrap up the main points from what you've talked to us about, it sounds like we want to be thoughtful about whether we are actually allergic to penicillin. And so that is a discussion we should be having with our physicians. There's more than one way to potentially understand whether we have a penicillin allergy. Sometimes we'll do something that sounds a little scary, like an oral challenge in the office, which just means we take the medication in the office and you do it in a setting that if you do have a reaction, we can kind of respond and make sure you'll be okay. Benadryl is something worth having on board or in the house just in case you have some sort of minor reaction or you're starting to develop a reaction that might be more severe while you're on the phone calling to get that appointment with your doctor. And penicillin is something that treats multiple different illnesses, otitis media or ear infection, strep throat, pneumonia. So it's a medication that we kind of need, and we should be careful about whether we actually have an allergy or not so that we can use the appropriate medications and not be at risk for this thing that sounds terrible that you've described called C. diff. Did I catch them all?
Definitely, definitely, definitely. It's just being aware and don't get surprised by your physician who might ask you more questions about it and maybe even ask you to take a medicine or go to an allergist. You know, this is definitely part of a national-wide movement toward really improving our understanding of penicillin allergy and help the community overall get more comfortable with this concept and not necessarily take penicillin allergy as true allergy all the time.
Yeah. Dr. Raffi, I so appreciate you coming here today. I trust Dr. Raffi with my own children. I'm so glad that we had an opportunity for everyone to hear his advice and his expertise. So thank you, Dr. Raffi.
Thank you. Thank you.
We're going to make a little pivot away from, and Dr. Ash, thank you. We're going to take a little pivot away from infectious disease and think a little bit more about our physical ailments and our ability to recover from when we've potentially been in the hospital, either recovering from an infectious disease or recovering from something else. But we're going to work to understand physical therapy a little bit more, what wonderful resources we have to recover from what can sometimes be difficult stays. So we have a lot of wonderful expertise here. We've got Dr. Anar Guru, we've got her colleague, Julie Tan, a bunch of wonderful expertise. I will let you introduce your team, Dr. Guru.
Hi, I'm Anar Guru. I'm the Dean of Health and Human Services at MiCHWA Community College, but also a physical therapist and have practiced for a long time as well as taught in physical therapy programs at U of M Flint and MiCHWA Community College. And I'm going to have Julie introduce herself next.
Hi, good afternoon, everyone. My name is Julie Tan. I am a physical therapist here at McLaren Flint Hospital. I have been a practicing physical therapist for about more than 20 years and have run the gamut of peds to acute care to geriatrics and subacute rehab and home care and outpatient, you've named it. My first love has always been acute care and geriatrics, so I am thankful for everyone and appreciate having the opportunity to join this webinar today.
And Jacob.
Hi, I'm Jacob. I am a MiCHWA Community College graduate from the Physical Therapist Assistant Program. I've been practicing for almost 5 years now, and I actually am currently in my first year for the physical therapy program at U of M Flint.
Wonderful. Thank you, Julie and Jacob. This is going to be a great discussion about physical therapy, and I think, Julie, we can start with you. Because we were just talking about infectious disease with Dr. Raffi, and you like acute care the best. Can you tell us a little bit about the role of physical therapy in acute care?
Yes, absolutely. So when we talked about acute care, I think we get a lot of students here too, like PT students, like Jacob, for example, and they always come into PT with this idea of sports and orthopedics and stroke rehab, for example. And nobody really ever sometimes comes in understanding what acute care is. And I also feel for a lot of the people in the community, they come into the hospital, they're admitted to the hospital, they're fairly vulnerable, they're sick or their family members are sick and they're very stressed. It's a very stressful environment for people in the community to just understand the resources that are available to them and their families that kind of gets everyone recovering and doing well. So therapy as a whole is an integral part of that environment. So we're going to talk about acute care physical therapy. What do we mean by acute care? Who are your members in the therapy team? And what exactly do we do for our patients and the community as a whole? I think if Heather can share some of the slides I have, that would be awesome. So we talked about what is acute care. So acute care, we're talking about you have been admitted to the hospital. You're here maybe because you're going for an elective procedure, perhaps a knee replacement or a hip replacement, or you're here because there's this acute medical issue that needs immediate medical attention. It's a stroke, it's a heart attack, it's an infectious process. You're running a high fever. You're not, mom's not like herself. She's really confused. You're very worried. You're bringing her to the hospital. She's been admitted to the hospital. Now what? Because your healing and your recovery is not just the medical side of it. We also have to look at the physical and functional side of that. And that's where therapists come into the equation. So if we look into the next slide, we talked about PT. I mean, I'm going to be talking more about PT, but I would be remiss to not talk about the other important members of the rehab team. So physical therapy in general, we're looking at your big mobility picture, right? How are you getting up out of the bed? How are you tolerating activity? Are you able to stand? Are you able to walk? What's going on with your systems? Is this something that you need care for? So we're looking at gross mobility pictures, balance and strength, and your ability to move safely within your environment. And then we also work with occupational therapists, and they're fantastic. They really work with activities of daily living. So your occupational therapist comes in and they make the assessments. Are you able to dress yourself? Are you able to use the bathroom? Are you able to do these day-to-day self-care things that are really important for you to be able to flourish and function well and safely at home? And they're doing that within the context too of, can you plan these tasks out? Some of these more complex multi-step tasks. Can you, when you go to the bathroom, are you able to dress yourself, undress yourself, wash yourself, do all these things safely and appropriately? Are you able to hold a spoon to eat? How are you able to feed yourself? So the occupational therapists are looking into those sort of activities of daily living. And then the other side of the equation too are speech language pathologists. So there's a lot of things that they do at the hospital as well. Number one, they look into your swallowing abilities. Maybe you come in and a family member has a stroke, which has affected their ability to swallow or eat safely. Or you're looking at maybe your grandma's come in, you notice that, hey, every time she eats, she does all this and now she has pneumonia. What's going on? Are we eating properly? Are we swallowing properly? And the speech therapists look into that ability to swallow safely, ability to kind of take in food safely. But not only that, they also work on your language, your ability to speak, your ability to understand, your ability to communicate. And also just these complex thinking stuff, your judgment, your insight. If you come in with a stroke and you're aphasic, which is a term that we use for people who have maybe can't talk, can't get their words out, or maybe are not understanding what people are communicating to them, speech language pathologists or speech therapists are an integral part of kind of moving the patient forward in that recovery period. So this is your therapy team while you're in the hospital. McLaren has a PT, OT, and speech team that kind of are working solely in the acute care side of the hospital. And a lot of these, your therapists come in and they determine your readiness for mobility. Are you ready as a patient, your family member, whatnot? Are you ready and safe to get moving, get working? Because it's really important from day one that we're really looking into these abilities, because so that way you lose them. So coming in to the next slide, we're talking about what do you see commonly at the hospital. So we've got wonderful local hospitals here in the area. You got Hurley when you have trauma cases, PEDS. McLaren is a comprehensive stroke center. We've got a wonderful cardiac program here. So we pretty much see anyone in the hospital that needs rehabilitation, right? The physicians come in, they make that evaluation, they make that consultative process and say, hey, the patient has all these deficits. Let's bring rehab into the program. Let's bring PT, OT, or speech. So we see a lot of these diagnoses, trauma, surgical cases, neurologic cases, your strokes, your traumatic brain injuries, fractures, joint replacements, congestive heart failure, open heart surgeries, people who are coming in with COPD or asthma, respiratory issues, pneumonia, infectious diseases, medical illness, debility, and deconditioning. So debility and deconditioning, that's huge. You're coming in and at baseline, when you're healthy, you're feeling great, you're doing everything for yourself, and then you're coming in or your loved one comes in into the hospital and you're just feeling horrible, right? You're sick, you're vulnerable, you're stressed out. It's just, you're just thinking about a lot of things medically that the doctors are managing, nurses are taking care of you. It's really important to get into the groove of being able to come in and do as much for yourself as you possibly can. So the thinking is, if you came in here walking, you should hopefully, you get out of this hospital walking too, right? The NIH has this wonderful study about people coming into the hospital when they're sick. And, the decrease in physical and cognitive function when you're in the hospital, in bed, off your normal routine, affects about 65% of like older adults, 55 years and older. So you're looking at the fact that it's not just the physical component of this, but your brain fog, your ability to kind of make judgment calls, and your insight, your ability to plan tasks, even if it's just your day-to-day tasks, are affected. The NIH did the systemic review, and they found that 87 to 100% of our adults, they're in bed. They're not getting up as often as they are. They're spending an average of 20 hours in the bed and maybe spending 43 minutes sitting, standing, or walking. So that's like 43 minutes out of a 24-hour day that's the only thing you're doing. And we're counting sitting there, we're counting standing, we're counting walking. So you can just imagine how deconditioned and debilitated one gets if we're not paying attention to their function and their physical abilities. You're looking at the fact that you can lose up to 30% of your muscle mass within just the first 10 days of being ill and being in a hospital. And that's a lot. That, for a lot of our older members, older adults in the community, you're already fighting an infection, you're already sick, maybe you've had surgery. Now, on top of that stuff that you're going through, you're also losing a little bit of that mass and function every day. And that can affect the way you can get up from the chair safely, the way you can get out of the bed, if you're able to get out of the bed by yourself. So these are things that therapists look at and work on just to kind of make sure we're addressing these issues from the get-go. So what is the role of PT during a hospital stay? So we move on to our next slide. And we evaluate and treat patients to optimize function, really. We want to improve their mobility. We want to make sure, most importantly, when you're ready to leave the hospital, what do you need? Where do you go? And mobility, there's really not a lot of stuff that keeps us from moving you. We want to move you. And we make this decision in a very collaborative team with our physicians, our nurses, everybody in the healthcare team kind of works on this to determine, are you ready to get up and move? So I primarily work in the intensive care and critical care units. So mobility starts from day one. So you can see this picture here. This is a gentleman. He's intubated. He's under vent. But when we determine that you're able to at least follow commands, able to at least have some reserve and some physiological reserve, we're coming in and we're trying to get you up and moving. So everything is just kind of geared towards that mobility aspect from day one. We also do safety assessments, equipment recommendations, and patient and family education. So we talked about moving forward, what kind of mobility aids do we need? What kind of support system do we need? What kind of other rehab services do we need? Because you might be medically ready and stable to leave the hospital. You're good, you're ready to go. And then you're like, but I can't even get up from the chair by myself. How am I going to use the bathroom? How am I going to get out of the bed? So these questions all come into play. So we work on that together. Another question sometimes patients ask me, how often do I see you when I'm here in the hospital? And I wish I could say every day, but that's not typically the case. Mobility in a hospital is everyone's responsibility. So nurses get you up, physicians educate and encourage, and really that's a big thing for a lot of patients. I feel like when it's very top down, everybody has this clear, consistent messaging that how important it is to get up and moving. Patients understand it a little better. Our community members understand that importance better, and they buy into this a little bit better. Because it's very hard sometimes to convince our patients to get up when they're hurting or they're in pain or they're telling me, I can't breathe, I don't know, I'm scared. So it's just a lot of this clear, consistent messaging from teams that everybody should be up. Your nurses and your therapists should all be getting up. Your physicians, our physicians should be directing that clear message. Family members and patients themselves should advocate. Hey, I want to be up to sit up for breakfast. Can you help me sit up? And if you are deemed safe and appropriate by the team members, we have to be getting you up. We should be getting you up. Okay. So if there's other things too, let's say you're still may be medically unstable, there's other medical issues in play, we take all of that in account. But if you feel ready and the team, decides, yes, you are ready, you should be up and moving around. Because unfortunately, in the realm of acute care, it's not an everyday thing. The goal of acute care when you're in the hospital is we want to medically stabilize you. We want to get you mobilizing, but we're really moving you forward to your next level of care. Where do you need to be to kind of get up set for success? So it's something that we do tell our patients, as much as we would like to work with you every day, it really doesn't, it's not realistic. It really doesn't happen, but you should be mobilizing every day. You should be moving every day, not just with your therapist, but with your nurses as well. So the approach to discharge planning is like a very much like a team approach. Everybody's kind of discussing, we're all figuring it out. We're, making sure that we're giving our community members, we're giving our patients the best chance for success, sort of moving forward as they go on to their, finish their care. So why is it important to move? So we're talking about mobility and mobility. So we're talking about the next slide over what the benefits of mobility are. And really it's just, I tell my patients, your body is made to move. It is not made to lay static in bed. It is not made to just lay there. You're made to get up and, just interact with your environment. It's good for your whole body. It's not just good for your muscles. And I kind of press that very much on my patients. It's good for your heart. It's good for your lungs. It gets your bowels moving. It's good for your mental health as well. There's something to do if you're laying in a hospital bed and your line of vision is basically the ceiling, like up here, right? And the ability to just even sit and kind of interact with your environment in a better field of vision is always better. So mentally, it's like you just feel a lot better getting up and moving. And it's also been shown that if you move more, early mobilization, getting up and moving more while you're here in the hospital safely by yourself or with staff, also leads to shorter lengths of stay. So you're looking at older patients maybe who are coming in with acute congestive heart failure or acute cardiac issues. If they're consistently up and moving while they're here in the hospital, their chances of going home directly after when you leave the hospital is a lot higher than patients who are kind of just staying in bed. And I could speak of, for example, here we do a lot of open heart CABG patients, so open heart surgeries and stuff like that. And that is like a very strict protocol here, for example, at McLaren, that when you are ready, the first day, even with all these people, patients are always, and families, for example, they're always surprised because there's all these lines, all these tubes coming out, but you're up in a chair. You're getting up out of that bed, And sometimes on post-op day one, if you're ready for it, therapy's coming in and we're walking you in the hallway with all your chest tubes and all your lines. And when it's established that, okay, you're tolerating activity well, everything seems to be doing good, we're upping that to moving 3 times a day for our open heart patients. So there's this just drive for mobility, or our stroke patients are optimized for therapy that, therapists are trying to really making that intentional effort to see our neuro cases, our stroke patients more regularly and more frequently. Moving after surgery, it's also really important. You're along with the physicians, the surgeons, everybody, again, it's a group thing. Everybody says, yes, we're ready to get up, we're ready to move, we're stable for that mobility, let's get you up and moving. And again, to kind of talk to everyone here, when we're talking about, I come in sometimes and then saying, I'm your physical therapist, and they come in and like, but I'm not ready. I can't lift stuff. And they're all thinking that I'm this gym instructor that's coming in with these 10-pound weights and asking to do all these things. And we always say, no. In this particular case, when you're ill or going through surgery, or you're done with surgery, or you're not feeling great, therapy is sometimes as simple as getting out of bed. How can you get out of bed? How are you tolerating it? We just want you to get to a point where you can go home and feel good about being able to care for yourself or move, or your family feels okay. Like, yes, we got it. We can provide the support at home, and so on and so forth. So it's just this, sort of nice progression of activity and mobility as you're going through while you're here at the hospital.
Yes. Thank you so much, Julie. You have a little bit more to share here, but I'm just really thrilled to hear your passion for what you're doing for some of our sickest of patients, and how mobility is so important, even just to start a little more circulation and improve alertness, because there's more blood flow to the brain, for example. And physical therapy is helpful in a variety of settings, not just for our sickest of patients. So my experience in the field, I've worked in inpatient rehab, which is the next step for a lot of your patients, Julie, I think, and then in outpatient. And my area of expertise really is in sports medicine. So that's another phase of physical therapy. I particularly like to work with dancers and performing athletes on recovery. And just a little note about that, when they are not able to be mobile in the way that they're accustomed to at that high level of mobility, it really does affect their mental health. So a physical therapist's role is to try to regain as much mobility as possible in a safe manner, with attentiveness to their injury at the time. And then once they're recovered, to regain that mobility at a very elite level so they can return to sport. And I think about some of the teenagers I've worked with, Julie, and how down they get when they're out of the game, so to speak, and how the physical therapist can really be the cheerleader for them, and get them going and give them opportunities for mobility once again in the way that is safe until they can do a little bit more. But this profession is helpful in so many different settings, for pediatrics all the way to geriatrics. And I think probably one of the most rewarding professions, because ultimately, whatever setting we're in, we're significantly improving quality of life. And mobility is indeed a big piece of that. And I think Flint is very, very lucky because we have great education programs for physical therapy, with PTA being a 2-year degree. It's an associate's degree that Mott Community College has, and then the Doctor of Physical Therapy program at the University of Michigan, Flint. And what I want to do is turn it over to our student who's with us today. His name is Jacob, as he said. He actually was my student when I was teaching in the PTA program. And like he said, he's been working for a number of years, but has decided to go back and get his doctorate degree in physical therapy. And Jacob, can you tell us a little bit about why you chose this profession, what's rewarding about it for you, and your educational journey?
Yeah, so I think I kind of got started interested in it, how almost every other physical therapist assistant does. I went through it myself. In high school, I dislocated my shoulder good amount of times. Ended up having surgery to repair my labrum, which is just like the little suction pad in the shoulder joint. So I went through that and got me back to sports, which I loved in high school. And I was like, man, this is great. I mean, I can only imagine how it feel. I mean, I felt great from my end as a patient getting back to it. I can only imagine how it feels from the other end of being the person to help the patients get back to their normal daily living. Um, and I just wanted to kind of find that out for myself. I started out at SVSU to start in like a pre-physical therapy path. And I didn't know much about it. During one of my classes there, I heard about the physical therapist assistant position. It's like, oh, that's awesome. I can get started in the field sooner. So I ended up going to Mott and got into the program there and had nothing but love for the program. I actually credit Mott with getting me on track for my life, not only professionally, but financially and emotionally with everything. I have nothing but love for Mott's physical therapist assistant program. Working for the past 4.5 years in the field, I have had most of my experience with home care, uh, outpatient, and then also currently skilled nursing for a few years right now. With my outpatient experience, like Anar was saying, I did work with a number of athletes, but I was in primarily a chronic pain clinic, and that was really rewarding just getting to help these people who for a number of years they were dealing with pain pretty much daily, help them to go a couple hours out of bed to spending most of their day out on their feet, getting to actually get out, move around, enjoy their lives the way they should be. With my skilled nursing job currently, I don't know if there's anything really to me more rewarding than getting to see a patient who is stuck not at their home, having to have their family come and see them, and then they can walk out the door and say, hey, I get to go home now. And I think everyone wants to be home. And it's pretty, I don't know. For me, it's rewarding. For the patients, sometimes patients are literally crying happy that they get to go home and they can go to be with their family on Christmas now because they just had to miss Thanksgiving for the first time in their 80 years of life. And it was the worst experience of their life. So getting people on track back to living their life how they should is really just, I can't even explain how good it feels some days. And, that's coming from me not having to go through all that, but just to help the people finally feel like they can be normal again. Quote unquote, they're normal, right? So I was like, man, what better way to really get better at that than to try to go back to school and get even more education and practice in the field. So I worked for the past few years to finish my bachelor's, and I was fortunate enough to get into U of M Flint and kind of start on my path there to getting a doctorate in physical therapy and keep on working in the field.
I hear you're doing very well in the program, and we are super proud of you. And it's been so fun to watch your journey. But I think one day you're going to be like Julie, really making a difference in people's lives, even when they're very, very ill. Thank you to both of you for helping to present this wonderful profession. It's my favorite profession, and I am very biased, but that's okay because I can say that with my whole heart. And we are really so lucky to have great educational programs to produce the best physical therapists around.
I think what I love about this discussion is we have run we started talking about the history of the webinar, and the webinar's history is in bringing information, trusted, credible information to community, both about health. But what you have done is sort of highlight what the opportunity for training to be a part of this work could look like. And we have been able to do that by bringing Dr. Ash's medical students, the medical students we get to share on. We've brought physical therapist students on now, and we have brought in the trusted expertise of people like Julie Tran who are doing the work in the field. And so I couldn't be more happy to see our institutions represented, our hospital institutions, our educational institutions. Thank you so much for the work that you do.
Thank you.
Thank you to everyone who came, has participated in the webinar. Thank you to community for being the reason why we are here. Thank you so much for all of the wonderful expertise. Please don't hesitate to let us know. Make sure those questions that you have for us, we're able to bring you the expertise you need or the resources you need. Again, these are the continuing education units for community health workers. We have been so happy to have the expertise we had. Thank you, Dr. Raffi. Thank you, Dr. Anar Gru. Thank you, Yvonne Lewis, and all of the wonderful people who have been at the center of what we've been able to do with the webinar. We will see you next month.